if you have any questions.
In any language, please.
Des questions en français?
Or in Spanish?
He will translate.
I have one just for starting. Regarding the articular involvement in lupus, you know, we are quite friends of methotrexate, and actually when we compare our two cohorts, the use of methotrexate in our cohort compared with yours, was much higher. And we don't feel people tolerate that bad. I mean, it's an issue, but probably doses over maybe 20 milligrams or so. But within the list of the EULAR, I think there's a missing step, which is adding mepacrine. And we're having a good experience in adding mepacrine to hydroxychloroquine, particularly adding mepacrine. Yeah. Particularly in patients with skin and articular involvement. And now it's our first step. I mean, after low-dose prednisone and hydroxychloroquine, if things do not well in the articular trend, we go to mepacrine and then to go with methotrexate. Have you got an experience with that?
You know, it's just impossible to prescribe mepacrine. And can you remind us how you prescribe mepacrine? How do you get mepacrine?
Hospital. I mean, they get us a foreign medication, so we just, I mean, they have a stock actually. The only problem with mepacrine is that they increase the price a lot over the last 2 years. But we just ask we have just a letter to the pharmacy of the hospital, and they get it, and patients, they have to collect the drug at the hospital, but it's very easy. It's 100 milligram pills. The only problem is that they're really yellow, and they smell like tire rubber. It's terrible. I mean, you don't feel like eating them.
That's not good for the placebo.
No, not at all. But for the rest, I mean, it's very well tolerated, except for some exceptions. But it was very well, and you cannot get anyhow.
No, it's impossible.
We try, you know, and I think it's just impossible because it will be very difficult to get the final authorization from the ANSM. So maybe we can talk about that with them. But I think Nathalie talked about mepacrine with a dermatologist in Paris. You told, and it's just impossible now to prescribe it.
Somebody has it in France. We tried with our pharmacy, but I'm not sure I will succeed. And the only way is to tell the patient to buy it in London or on the internet or in the Geneva.
It's funny because in the dermatologist guidelines, it also in the European ones, who are led by German people, it also appears there, the mepacrine. So it's there.
In some countries you have it, but we don't have it in France. And I would like to have it for the patients with toxic retinopathy because it seems you could use this.
We will be with Nathalie in 1 week in the ANSM, so maybe we can take the opportunity of this meeting to talk about mepacrine. But yeah, that's very interesting to do that and to be able to add mepacrine to hydroxychloroquine. About methotrexate, it's very difficult to tell if a patient will tolerate methotrexate or not. Sometimes you have a very strong guy who cannot support it, and you have a very old woman, very thin, and it's gonna be fine with it. So you just have to try. After, you know, sometimes if they have some hepatic, some trouble with the tolerance, you can switch the oral administration with the subcutaneous administration, and sometimes it's better. You can increase the dose of folic acid. You can divide the dose, the oral dose, 1 pill in the morning and 1 the evening. But you know, sometimes you cannot do anything. They cannot tolerate it, and you have to switch to something else. And I don't think leflunomide is a solution in this kind of population. And I wanted to highlight one thing. At the end, in the conclusion, we said you don't need to use more than 10 to 15 milligrams of prednisone. But most of the time, you need to use less than 5 milligrams of prednisone for joint involvement. What we wanted to highlight is when you need to increase the dose, that means something is wrong. I think that means it's not maybe a regular joint involvement. So first, you need to understand what's going on, and maybe you will find something else. I don't know if we'll find the solution, but you will understand you don't need to increase the steroids because it's something else. And it's maybe a vascular involvement, and you can increase to 30 milligrams. It won't change anything.
We are yesterday with Natalie. We were talking about this vague symptoms of pain everywhere and tiredness and so. And that sometimes, as Christina said, for the lung disease, I mean, the extra pharmacological things are very important. And I think there's an epidemic in our environment is a sleep disturbance. People do sleep very, very bad. And when you sleep bad, you feel poor. And many times, only sleeping better improves your general state, including joint pains. So I think something we should always ask the people and try to get them sleep better, do some exercise, don't lose muscle mass. So this also helps. Do you really perform the ultrasound in the clinic just to be sure that there is joint involvement? Because we don't do it. We are not rheumatologists.
No, we do it sometimes, but be very careful with that because you really need to improve the skills of the person involved in the US, because most of the time they are used to do it in rheumatoid arthritis, and if they do it in lupus, they will search for exactly the same things, and it's just impossible. It's different. So that's why I think we have some collaboration for clinical management of patients with ST, and we talk about that. I told her it's just impossible to be sure a patient has joint involvement with US, because you wanted sometimes to know if it was fibromyalgia or joint involvement, and you thought maybe ultrasound can be the solution, but we cannot do that. We don't have currently the right skills to be sure about US exam. So I think that's very interesting. You will have Ishasho next week with a new diploma, because it's today. I hope so too. And so maybe you.
Yeah, I think this is in our plans, that taking her to the clinics with the echo and try to find something. But once she's gone, we cannot do anymore. So
we will find someone else.
Guillermo, when you consider the pathogenesis of lupus, there is something which is starting to be addressed, and this is something which is probably very true for the joint involvement. Is a link between the neurological aspect and the immunological disorder. When you have pain and at the joint, okay, so maybe you have a synovitis, arthritis, but it could be also that you have something which is directly linked to the pain and to the sensation of the pain. And when you give just interferon alpha to somebody without any lupus, you are gonna have some pain, okay, but without any synovitis. And this is something that needs to be taken into account. Sometimes you have, let's say, an immunological driving pain, and sometimes it could be a neurological driving pain. And this is something that needs to be addressed, and that this will be addressed in the near future, I think.
Are you?
Maybe it's work for
the no, that's
recording.
Yeah. Are you aware of any effect of this, of any problem of all this interferon?
No, but in the field, in terms of pathogenesis, we are discussing about this aspect because we have all of the discrepancy, the clinical examination. Clearly, I cannot distinguish those aspects. Maybe the ultrasound is going to help a little bit, but when by the end the pharmaceutical companies, when they all want to give some good medication, basically they want to give a very expensive medication that's going to improve the disease. So, well, it could be important, but by the end, at the very beginning, you need to start explanation about the pain. It could be inflammation, but it could be something else, particularly in lupus. When you consider interferon alpha is something which is clearly the neurological system. Clearly, plenty of good paper in this aspect. And the neuroscientific guide are telling us that clearly it's impacting the neurological function, but also the pain sensation, etc., etc.
I have a question for Christina about the anti-synthetase syndrome. When you treat this patient with tacrolimus, you used to add tacrolimus to MMF, or usually you use it alone with the steroids?
When it's for interstitial lung disease, we always use mycophenolate. And we sometimes add tacrolimus, but some other times when we treat muscular involvement or skin involvement, I think that the best combination, at least for me, is methotrexate and tacrolimus at low doses of both of them, but I have good results with that combination.
This is this is a trend we have. We try to add on things instead of substituting. And especially the calcinuric, also in lupus nephritis and so on, we usually use as a second drug. And we are actually very happy with that. I mean, we have discovered tacrolimus over the last 5 years with the nephrologist thing. And it's very easy to use. You have the blood level, so you more or less are confident that patients are taking the drug. The toxicity is not high. I mean, maybe in the long run for the renal tissue can be a little toxic, but it's very good. So we tend to use very much in myositis as an add-on therapy.
Yes.
I have a question for Cécile and also for Guillermo and Nathalie. What do you think about, the EULAR recommendation for SLE diagnosis and, the entry criteria and the ANAs above 1 to 80?
So during my talk, I talked with you about the likelihood ratio, and you need to know that ANAs and anti-nuclear antibodies are detectable in many people with no disease at all. If you are old, you have anti-nuclear antibodies up to 1 to 320 or over, and these people are just old. They don't have any disease associated. So it's very difficult to interpret so low titer of ANA antibodies. So it might be an issue when you detect this kind of titer in patients which just have joint pain or something, and make this a lupus just because they have a low titer autoantibodies. So it's difficult I think, for diagnosis, because the likelihood ratio will be very, very bad. But in another hand, real lupus patient can only have 180 NA titer. So how can we manage? So we need to, I think, to inform general practitioner about the interest of anti-nuclear testing and in which kind of patient you can find NA positivity, and to know that all people have NA positive and they are not ill because of that. That inflammatory disease have also anti-NA. That toxic drugs can lead the presence of anti-nuclear antibody, but also cancer, but also infection. So what is the likelihood ratio?
So I have to start. I was involved in the criteria, and Guillermo also. I'm not very happy with the 1/80. I was there, and I tried to obtain 1/ at least 160, but I was not successful. But Guillermo will also say things about that. They have studied that, and it appears that it's as good as 1/160. So, but I would have preferred, at least in France, we consider that 1/80 is negative. But it's not the same in other countries.
Well, actually, I think the criticism was on the other side. So some people say that you cannot use ANA positive for an entry criteria because you are forgetting ANA negative lupus, which for sure they do exist. The point again is this is only for classification purposes. This is not diagnosis, this is classification, and this to assure inclusion of patients in the clinical trial. So the aim is for specificity. So the idea of choosing ANA positive and entry criteria was for specificity. And they performed some ROC curves, and they found that between 180 and 160, there's not much difference. So with 180, sensitivity was a little bit higher. So this is why they decided in this way. There also, regarding the criteria, there was a change in the area you covered, the arthritis arthralgia. In the beginning, this process of the classification criteria was very long, and with many people involved. And so Natalie and myself, we were involved in different phases. So I was involved in the phase of. No, we didn't meet actually. No. And I was involved in the phase of waiting, of giving the specific points for each criteria. Okay, and at that point, only arthritis was the criteria, no arthralgia. Okay, so there was a big discussion because we all know that many patients with lupus have a lot of pain, but no signs. Okay, and also from the patient's side, because there were also patients involved, they insisted on that. And then when they added arthralgia to arthritis, all the numbers about sensitivity and specificity improved. So this is why they decided also include arthralgia with morning stiff pain like Patrick has every morning.
And you didn't discuss to give less points to arthralgia than to arthritis, because that could be 6 points for arthritis and I don't know, maybe 4 points for arthralgia?
They checked the way the calculation of weighting was done was very funny. They presented several cases, and then there was a guy then, and they presented two scenarios. Okay, for instance, a person with pericarditis plus DNA versus pleural effusion and ANA positive, and you had to vote which of these two are more likely to have lupus. So all this voting went to a software, and the software analyzed, and the software gave the weighting. There was a gray zone, so the patients in which there was not a high degree of agreement, we had to retest again, we discuss again, and reach an agreement. So this is why so it was not something that we did by ourselves, saying, I think 6 is better than 8. No, the software calculated that. And I think the arthralia entered after that. They gave the same weight, and with that scenario, the numbers of sensitivity specificity were good. So I think it's how the thing acts.
I just would like to remind to the young fellow that having NA 1/80 could be normal. Okay, the way the immune system evolved and the way the T and the autoreactive repertoire is out of the game is very clear for, let's say, all the autoantigen, the tissue-specific autoantigen is not as clear for the DNA. One of the main reasons is the DNA is an autoantigen, clearly, for the lupus, but the DNA is also important for bacteria and viruses, okay? So when you want to fight against bacteria and against viruses, you need to be able to mount an immune response against DNA. It's not exactly the same DNA, clearly, but you need to be able to target those kind of antibodies. So remember, when you have NA at 1/80, well, it could be normal.
Yeah, but you know about the classification criteria, I worry a little bit because I think a lot of people in the future will use as a diagnosis criteria, and especially because I'm a rheumatologist and I know about spondyloarthritis, and the entry criteria is low back pain, inflammatory low back pain. It's just a nightmare now to manage fake spondyloarthritis. Yeah. So I worry for the future because I don't want to manage fake lupus.
Okay, thank you. So we are going to stop now for 10, 15 minutes? 15 minutes, and we will come back. Thank you.